Okay, now we're going to talk about the Asia Impairment Scale, or AIS, which is a physical examination that we're going to do as part of our evaluation. This is actually the international standards for classifying a spinal cord injury. Sometimes you'll hear it referred to as INSCE, but primarily you'll hear ASIA. It's a standard physical examination, which includes a dermatome-based examination, a myotome-based examination, and an anorectal examination. Now, I use the terms dermatome and myotome based because these are different than when we typically test dermatomes and myotomes, and we'll talk about why that is. Primarily, this is performed early on, as early as 72 hours after the injury, and the test is standardized to be in a supine position because we're assuming that we will likely have to keep the patient still for a certain amount of time. And this way, it can be standardized from the early episode of care all the way through their entire episode of care. This predicts walking function if we find that there is some pinprick sensation, either totally intact or partially, in the perianal region. During the first year, there's usually a high rate of change in that AIS to hopefully a better classification. We expect some sensory and motor recovery as that spinal shock resolves. Between 1 and 5 years, there's usually little change in the AIS classification. However, we have seen some walking-based programs for AIS levels C and D, which you'll understand a little bit more later what that means, that they have improved motor scores in both subacute and chronic spinal cord injury, which is pretty encouraging. Now, we've seen this sheet just briefly in one of our other recordings, so I just want to take some time to get a little bit more acquainted with it. So if we look and we see that we're recording things for both the right-hand side and the left-hand side, and we see that they've included on this score sheet some of the key things that we're going to need. This is, it looks overwhelming, but they've done it so that you have all the information with you right there on the sheet. And you have your physical copy with you. You can see the front and the back, and we'll talk about both of those. But here you can see they have the sensory scale for you and how you're going to grade the sensation. And that will be done for two different areas here, light touch and pinprick, which we'll talk about later. These are both for the right-hand side, as well as light touch and pinprick on the left-hand side. They also have your motor grades here, right there on the paper for you, and those will be just for certain key muscles that they have found are the most reliable for this examination. So you'll be recording those here, here, and on the other side here and here. Okay, on the back side you'll see all the directions that you need to be able to do it. Again, it looks overwhelming, but after we've gone through it a few times, I think you'll find it really helpful that they've included all this. So we're going to focus on the next few slides on the actual steps of going through the classification. So we'll go through this step by step, but they're all written out for you here. A few things I want to talk about. Once when we do our sensory grading, we're going to think about the fact that we're doing it in a supine position, which is a little different. In addition to that, we're comparing both light touch and pinprick sensation to the cheek. So you're going to test both of those modalities on the person's cheek and then ask, first of all, if they can feel it, and then does it feel the same as their cheek. Now, you have not yet learned the sharp and dull or the pinprick test, but we're going to practice it in lab. You're going to use a safety pin, and the sharp part will be the sharp or the pinprick, and you're going to contrast that with the rounded part as dull to see if they can tell the difference between those. So don't worry, we'll get to practice that in lab. But now if we look at the muscle function grading, those grades are going to look suspiciously close to what we're typically used to doing, but there are going to be some differences. Again, everything is done in a supine position. Another thing to note is that there are no half grades. And we're going to talk a lot about this more specifically as we move forward. These are the 5 steps in the AIS classification. I'm not going to read them to you because we're going to go through them step by step together. The first thing that we're doing is determining the sensory level of impairment. Again, we're comparing to the person's cheek with both light touch and pinprick. Now, if you can tell right away that it's intact, then you don't necessarily have to do 10 times. But if you're having trouble or they're slightly inconsistent, they recommend doing 10 times, and if the person scores at least 8 out of 10 of those correct, then they get a 2 for normal. If they're inconsistent, less than 8 out of 10, then they get 0, it's absent. If what they do feel is different from the cheek, if they can feel it at least 8 out of 10 times, but it's different from the cheek, that's when you would score a 1. And you're going to score those, you're going to write those in your form right here for light touch, for the right side and the left side for each of those levels all the way down, and the pinprick the same thing for the right side and the left side all the way down. When you're finished with that, you're going to total, you're just going to add up the whole column and put the total down here at the bottom of each of those columns. The last thing that we're going to do is to find that most caudal segment of the spinal cord that has normal sensory function in both light touch and the sharp dull. So you're going to look at the right side and find where you have a 2 for both the right and the left side. And you're going to write that in on the right side here for sensory. And on the left side, you're going to find the level. Could be C6, C7, C8, T1, any of those levels where you have a 2 on both of those sections, and you'll write that level here. So that will be the sensory level of impairment. We're going to move on to the motor level of impairment. This is going to be the most caudal myotone with normal muscle function. Now remember, each segmental nerve root innervates more than one muscle, and most of our muscles are innervated by more than one spinal segment. So the way that they have standardized this is that if a muscle has a grade of at least 3, it's determined to have intact innervation, okay, from that more rostral innervating segment. The next most rostral key muscle must be a 5. That way it would be assumed that they will have both of its innervating segments. So a key muscle must be a grade of 3 or better to be considered intact, and the key muscle above it must be a 5. And we'll take a look at that in just a minute. So remember, again, we're doing this testing in supine positions. There are no half grades. Now, it looks suspiciously like our muscle grades, but there are some key differences. The first one is that we must have full active range of motion against gravity. If you don't, it gets scored as a 1, okay? Because to get a 2, you must have full range of motion with gravity eliminated. To get a 3, you must have full range of motion against gravity. To get a 4, you've got to have that full range of motion against gravity and be able to tolerate moderate resistance in a muscle-specific position. Again, these are going to be slightly different. They may look a lot like ours, but because they're in the supine position, they're going to be slightly different, and we're going to go through that in lab. To get a 5, again, full range of motion against gravity with full resistance in a functional muscle position that we would expect from an otherwise unimpaired person. So if we take a look at this in the motor exam, say we had a 5 here for the elbow flexors, a 5 for wrist extensors, a 5 for elbow extensors, and a 3 for the finger flexors, and then assuming we had maybe zeros below that, the level would be a C8, okay, because we have a 3 and the next segment above is a 5, so we consider this normal for C8. So C8 would be our motor level on the right side. If this were a 4, then this would no longer have a 5 as its next most rostral segment, okay, so we would no longer be a C8 level. Now this is at least a 3, C7 is at least a 3, and the next segment is a 5. So this motor level would be a C7 in this example. Okay? We're going to talk a little bit more about this portion when to test non-key muscles in just a few minutes. There are some exceptions to motor testing, especially when we have areas where we do not have key muscles. That's mostly at C2 to C4, T2 to L1, and S2 to S5. We don't have clinically testable muscles there. So we're presuming that the motor function is going to be the same as the sensory level. By the same thing, if we have impaired sensation, then we're assuming that the motor function is considered impaired. We're going to find the level where we have intact normal, which would be 2s on both sides, and then as long as the muscle above it, T1, so say we have 2s, 2s, 2s here all the way to T4 across, and these are either 1s or 0s below, then it would be a T4 level if this T1 level is normal. Again, once you have all of your numbers for the key muscles, you're going to add those up and put the totals down at the bottom of the column. And again, you're going to put non-testable if you can't test the area for any of these reasons. And if you are assuming that the grade is because of a non-spinal cord injury problem, then you're going to put an asterisk and you're going to document it here where I've got a pink box around that area. So any abnormalities get documented there. Then what we're going to do to find the motor level is go back up and find the area where we have normal motor function. We're going to calculate it for the right and the left, and we talked about this above, and you're going to write that in here. So the first example that I gave from the last slide was a C8. So we would put that on the right, and the second example was a C7. If we assumed that was on the left, then we would write C7 there. And again, if it's in these non-testable areas, then we are assuming that the motor level is the same as the sensory level, as long as the muscle above is intact. Here's a slide that you can go into to see all the key sensory points, as well as the key muscle testing. We're going to be doing this in lab, so we'll get comfortable with that in lab and the difference in the positions and how to go about doing the testing. The next portion, we're going to be determining the neurologic level of injury. Okay, this is the most caudal level of the spinal cord with normal motor and normal sensory functions on both the right and the left sides of the body. Just a reminder that the motor is normal if there's a 3 and the level above it is a 5, but sensation has to be 2s for both pinprick and light touch for that to be normal. So we're going to come across and find the place where we have our motor level is intact and all the sensory points are intact, and those are on both sides. And that will be the neurologic level of injury. After we've determined that, then we're going to move on and determine if it's complete or incomplete injury. A spinal cord injury will be complete if we have no voluntary anal contraction. Don't worry, we are not going to practice this in lab. I think you'd have to be in a pretty specialized setting if you're going to be the one that's going to be doing this, and you'll be trained appropriately. The voluntary anal contraction is here, and that's just a yes or a no. And then we're also looking at the light touch and the pinprick for S4 and S5, remember on the right and the left, as well as a deep anal pressure, and that's going to be a yes or a no. We're going to look all the way across there, that section, to see if we have a no, a 0, 0, 0, 0, and a no. We call that noon. If we have noon there, then we automatically know that this is a complete spinal cord injury. Otherwise, it's going to be an incomplete injury, and we're going to go through the classifications now. Once we have whether it's a complete or not, we're going to move through the little flow chart, and that's, again, on the back of your sheet. So here are the definitions of the grades. That AIS-A is a complete injury with no sensory or motor function at the sacral levels S4 and S5. Now, we're going to think a little bit about a complete injury. Again, we just talked about that. But an incomplete injury is when there is some partial preservation of sensory or motor function at S4 and S5. A term that you'll hear is sacral sparing, and that's just the presence of either sensory or motor function at S4 and S5. But some other terms that you're going to hear are sensory incomplete, which means that we have sacral sparing of sensory function, and motor incomplete, where we'd have either sacral sparing of motor function or sensory function and motor function more than 3 levels below the motor level. This is the part that includes non-key muscles. We come up to the flow sheet here on the right-hand side. Is the injury complete? If yes, again, then we know that it's an AIS-A. If it's not complete, then we move down. Is the injury motor complete? If yes, then we have an AIS-B. Okay, that means that there's some sensation and it's a sensory incomplete. Now, if not, if there's no voluntary anal contraction or motor function more than 3 levels below the motor level on that side, now we have to make sure that we're adding in some of those other muscles to see if there's any motor function more than 3 levels below that motor level. So we're going to go over the chart that helps you look at that in just a second. Then we're looking to see if there's at least half or more of the key muscles below the neurologic level of injury that are graded a 3 or better. Okay, so you're literally just going to look at your sheet and count up the number of 3s below the level of injury out of the number of key muscles that are remaining. Okay, so if it's not more than half or more, then it's an AIS-C, and if it is, there's also an AIS-E, which is normal sensation and motor function in all segments. Now, we don't give any individuals that never had spinal cord injury an AIS-E. This has to have been a person who has previously suffered a spinal cord injury and now has recovered normal function. Here is that section of when to test those key muscles to determine between the AIS, B, and C. Okay, so that's when you're going to go and test the other shoulder, elbow, wrist, finger, and thumb for the upper extremity, and etc. for the lower extremities to see if we have motor function 3 levels below that neurologic level. So the zone of partial preservation is the last portion. Here we're looking for dermatomes and myotomes caudal to the sensory and motor levels with partially preserved functions. Okay, so we're looking for the lowest, the most caudal segment that has either some motor or sensory, and we're going to write it down for both the sensory and the motor on the right and the left side if we have a complete injury. So we're really only marking the zone of partial preservation in a complete injury. So if you have absent motor, no voluntary anal contraction, then that's when you're going to record a motor zone of partial preservation. And if you have absent sensory, either the light touch or the pinprick in S4, S5, or the deep anal pressure, then you're going to record a sensory zone of partial preservation. This may be changing, but for our purposes for this exam, that's what we're going to go with. So we're only going to record a zone of partial preservation in a complete injury. So this has been a lot. So here I've got the link for you, and this is posted on Moodle, the overview from Physiopedia. You've got the scoring sheets for you to print extras for when we go through things. We're going to do that in just a minute. And you've got ASIA testing, the sensory points and the motor points that were linked above. And another video for you to watch if you want to see this in action and some of the common errors that people will make during the exam.